Interprofessional team immersion, collaborative and patient-centered care. What was the IPTI challenge? Our objective was to work together as a team to collaborate to provide the best patient-centered care for our patient through telehealth communications. The professions represented on the team are social work, pharmacy, occupational therapy, nutrition, nursing, dentistry, medicine, and the faculty and student leaders. We chose the sponges because we felt that that represented all the professions.
So for our case study, we had the opportunity to work with Charlotte, a 6-year-old with chronic asthma, and her and her family recently moved from the city to a more rural area where they are struggling with socioeconomic and cultural barriers for support and resources. And they're reaching out to us to navigate this situation a little bit better.
My name's Kiara, and as the RN on the team, my goal was to really gather information about the patient and understand the issues that they were facing, as well as working with my team, both patient-facing and behind the scenes, on how to collaborate and best give resources. My biggest takeaway was that patient needs are fluid, and as a care team, we also have to be fluid with how we work with the family and the patient to meet their needs.
I'm Juwan. My role was the occupational therapist, and to add on to what Kiara was saying, yeah, team collaboration was very important. It was important at the start to know what their unique skill sets were, so that you could be able to kind of tailor interventions and how to word questions the right way in sessions. And one reflection that I took away from this was like building rapport with your teammates and also with the client as well to help improve the quality of care.
My name's Heather. I was a social worker and I advocated for the family. I helped provide emotional support for them. I helped them to develop coping strategies and make decisions navigating this difficult situation. I was also involved collaboratively with professionals to address the complex issues, and I acted as a case manager to help make sure the family received the supports that they needed.
Walking away from this challenge, we really understood that empathy and holistic care for the patient and their family is key, and that as healthcare professionals, our roles often overlap, which creates an opportunity for us to be creative and collaborative in how we address the needs and the desires of our patients. Thank you so much for listening, and we're ready for questions.
Great. Thank you, Kiara, Heather, and Juwan for your presentation. It looks like our first question is coming from Provost Mike Sheldon. Go ahead, Mike.
Good afternoon, everyone. Great presentation. I guess my question, if I understood this correctly, this case involved telehealth. Is that correct? And so my question is, in the context of the challenges that you identified for this particular family, how did the technology issue work? We know of some of the challenges here in a rural state like Maine. You know, how did the whole telehealth platform work for this particular family, and how did you navigate challenges that you encountered with that?
That's a great question. I thought actually the telehealth portion of it was the hardest part for me because I'm used to seeing patients in person. So the very first interaction, like I got on and started asking questions before I even introduced myself, because I'm usually in the habit of like going into the room, talking to the patient, then introducing myself. So for me, doing it on telehealth was a total brain switch of how I needed to function and work. And I think we talked a lot about how like reading people's emotions and their kind of reactions to things was so important because we don't have the full body language and whatnot to be able to read off of. So it was definitely a challenge and worth the challenge, I should say. I don't know if Juwan has any other insight to that.
Yeah, I could kind of add on to that too. I guess like my approach is, I've never been in this situation before, and kind of taking a first time approach would be kind of empathizing with them as well. They're in the same position as us. And it's probably their first time interacting with the multiple disciplines. That could be overbearing. So we kind of approached it where we introduced ourselves, our roles, our names, and what we'd be doing. And then we kind of tailored that to more education, and that's kind of how we approached it as a team. So
we really still tried to have warm handoffs which I think was the key there in helping our family that we were working with feel like we all were on a team working with them together and not just scattered faces. So that was something that definitely helped as well.
Kiara, I love that concept that you just mentioned of the warm handoff and how it's critical, obviously, in all healthcare, but how even more imperative it might be in this virtual context for people to really make sure that that thread doesn't necessarily get lost. I'm hopeful there'll be more questions from the rest of the room here, but I was curious. You had talked a little bit about what having to build a rapport amongst your teammates, as well as in this complex case that has both a parental caregiver situation as well as the primary client being a child. What was that experience like to build rapport both within your team and then with a pediatric client as well as the primary caregivers for her? Was it hard for you? Was it easy? Did it come naturally because you have a background? Tell us a little bit about that experience for you.
So I think a lot of it, like I kind of mentioned earlier, like you get into this situation and then now you have to figure out, okay, what's the role of nursing, dentistry, social work, and all the disciplines combined, and figuring out, okay, what are our strong points? Where can we place everybody in the right position? They could be a good fit. And then from there, kind of building that rapport as well with team bonding too. We kind of how we created the name of the sponges was, I think someone might have mentioned something about SpongeBob, and then it kind of just spun off from there. We had help from Dr. Siegel and everybody else, and I think kind of making it lighthearted, joking, not taking it too serious. I think from that point, we kind of had that rapport with each other. We kind of understood where we were coming from, and to kind of position ourselves in a way where we could now approach and kind of tailor a session based off of the information we've gathered in the first session. So we went in there, we introduced ourselves, and I think we started with Sarah. She was the comm student. No, sorry, we started with Kiara. Kiara jumped in there, initiated everything, did a great job gathering information. And then we kind of, like she said earlier, we did a warm handoff with, I think, Sarah, who was the comm student. And it was, and it kind of just like, I think it went pretty smooth from there. And we all were able to kind of debrief afterwards and agree. There wasn't a lot of disagreement, but there were a lot of exchanges of like creative ideas and information passed around from each other. So
Hi everyone, I'm Sam Caldwell,
And I'm Emily Susie.
and we're representing IPD's Team 4, the Passionate Pandas, in our presentation of utilizing telehealth in a multidisciplinary approach to treat a patient with allergen-induced asthma. We would like to take this opportunity to express gratitude toward all involved in the making of this project. We couldn't have done it without you, so thank you. A truly shocking statistic describes that children from socioeconomically disadvantaged and minority backgrounds have higher rates of asthma, more frequent asthma flares, higher mortality rates, and require emergency room and hospital care more often than their non-minority and economically advantaged peers. Knowing this information, we believe as healthcare professionals, it's our responsibility to do all that we can to remedy this fact. Our goal for this project is to take a multidisciplinary approach to care for our socioeconomically disadvantaged patient with allergen-induced asthma. The utilization of telehealth made the treatment of our patient more attainable. Charlotte So was our 6-year-old patient who was recently had to move out of their urban apartment into a larger home in a more rural setting. The home is full of allergens that have forced Charlotte to go to the urgent care frequently and even got hospitalized for a couple days. Our care team was directly communicating with Charlotte's parents due to her young age. The telehealth appointments allowed the Sotos to voice their concerns regarding Charlotte's lack of continuity of care, their financial hardships, and concern with the current pharmaceutical approach to her treatment.
So for appointment one, we had the nurse and public health official go in to get some background, as well as the physician and dentist to answer any pressing issues. For appointment two, the first half of the appointment, the nurse, physician, and occupational therapist went in to answer any more questions and provide background information. And the second half was the occupational therapist and community health worker, as well as to recommend any alternatives that Charlotte can utilize. So our biggest takeaways was teamwork. We learned how to work as an interprofessional team and to remember what our areas of expertise are. We collaborated behind the scenes as well as in the appointments to get the best information we could. And continuity of care, we wanted to ensure that we continue to have someone that the SOTOs would know for each appointment, whether it was a nurse or physician. And that is all. Thank you.
Great. Thank you so much, Sam and Emily. Anyone have any burning questions at the moment? I, of course, do and will. So you can bank on that. So I was curious how your team went about deciding who went in for those different appointments. It looks like there was some decision making that you made from where you started, and it looks like a couple people were repeats. And sort of how did your team go about deciding who went in to participate on the telehealth session?
Yeah, so for the continuity of care, like I mentioned, we wanted to make sure that each individual appointment, there was someone there that they had previous experience with. So a lot of times it was the nursing student who went in, and she often introduced whoever she was going in with. Because we decided to start out with the public health official, which was myself and the nurse, to get all the background information that we could get. And then we wanted to address all their pressing questions because, like any mother would, she had a lot of questions in regards to all the medication she was on, the weight gain, a bunch of different things that they wanted to address. So we focused on splitting it up into these groups so that we could I lost my train of thought. I'm so sorry. We could address each individual need while also getting every profession that we could into the appointment.
That's great. The next question I have for you, and again, please feel free to raise a hand or jump right in there, audience, if you wish, but how do you feel like this telehealth experience might prepare you for your future career, or will it?
Yeah, so I worked with telehealth before during COVID. That's when I have a background in medical assisting and I trained during COVID. So I have a lot of experience with telehealth. And so going into it, I knew what to expect. But overall, I think it's helping my profession because it's going to allow me to communicate better because I'm not very good at communicating over Zoom. I am a very reading body language type of person. So it was interesting to say the least, especially for the OT student. That was one thing that he mentioned was he relied on body language. So yeah.
That's great. Thank you. And then last question, if you don't mind answering quickly, is how did you feel about the 20-minute time limit?
Oh, it was a great time. No, we struggled with it. The first appointment, it was supposed to be split in half, and we ended up taking the entire 20 minutes for background information and just doing it between those. It was difficult to stay in that 20 minutes.
Well, thank you for your honesty and candor about that, Emily. I'm sure you weren't alone in that.
As part of the Public Health Interprofessional Training Program at the University of New England, we were tasked with developing a fictional case and investigating potential public health interventions. So today we are discussing a case of gestational hypertension and diabetes. Our patient is currently 28 weeks pregnant with her first child, and she has gestational hypertension and diabetes. She has had hypertension for the past 4 years and was diagnosed with prediabetes 1 year ago and now has diabetes. She has previous opioid and alcohol use disorder, she is a former smoker, and she is currently obese. Some of her behavioral risk factors include the fact that she is unable to maintain a regular exercise schedule and consumes a lot of cheap and convenient fast foods. She feels as though she is unable to implement lifestyle and behavioral changes to control her diabetes. She works as a CNA on the night shift 4 times a week, lives alone, although sometimes her on-again, off-again boyfriend will stay with her, although he has a history of domestic violence. She does not live within walking distance to any public trails and does not own a car. Fortunately, she does have some protective risk factors, including the fact that she has full health insurance coverage and a comfortable annual salary. She walks to work every day, has a supportive sister who lives approximately 45 minutes away, and has overall good family relationships and strong connections with her coworkers. She identifies as African American and female and is a Somali immigrant. Some of the potential interventions we identified include assisting our patient with applying for the Special Supplemental Nutrition Program for women, infants, and children, which provides supplemental nutritious foods for patients who are pregnant. After pregnancy, we would assist our patient in applying for the Supplemental Nutritional Assistance Program, or SNAP, which is essentially the same as WIC, although not for pregnant patients. We would also provide her with information about the YMCA in the Auburn-Lewiston area, which would allow her the opportunity to meet others in the community and take advantage of the fitness classes. Additional interventions include identifying Somali support groups, for which there is one in Lewiston, Maine. This would provide her with an increasing sense of community. We have also identified the Catholic Charities Refugee, which assists with employment, completing job applications, and assurances of basic needs. We also would provide her with information on Caring Unlimited, which provides resources and counseling services for victims of domestic abuse. Thank you.
Great. So Tessa, Drew, Ariana, if those of you in the room can just kind of wave so we know who you are. Okay, great. Thank you. So we know we got a couple folks here. Feel free, like I said, raise your hand or just unmute if you've got a question. I was curious, given just the complexity of the variables, both positive as well as potentially some challenges, how did your team manage prioritizing for this client?
That's a good question. I think that some of the things that we felt were the most important to manage were the things that were going to impact the pregnancy right at this moment. So obviously figuring out the hypertension and diabetes, and then sort of some of the other things that seem to be, although very important, but maybe they could be handled at a later date. I think we chose to implement interventions that were going to take care of what we felt was the immediate problem.
My next question for you would be, it seems like you found some wonderful resources in the community to meet both her immediate needs and potentially future needs. Do you have any tips and tricks for the rest of us as we try to find that balance for clients to not overwhelm them with all of the options all at once? Did your team have some tips and tricks for the rest of us? Or anyone in the audience?
Yeah, I was going to say I can chime in. This was sort of not a totally fictional case, but we never actually like implemented it to like this person. But I have had to reach out to patients before to like let them know of resources that exist similar to this, where like they really have a lot of needs and there are a lot of resources that we can give to them. And I feel like how I've approached it with my patients before is seeing how they come in that day, if they have expressed any specific concerns, like sort of dealing with that in the moment, and then advising them on a resource for that versus like giving them a list of all of these things, because in my patient's experience, like their life is already overwhelming. So giving them so many is an additional overwhelming factor. So for me, in my experience, that's sort of how I've done it, is sort of over time, as you continue to build that relationship, give them more and more resources as you go.
Go ahead, Emily. Please jump in. Thank you, Drew.
Sure. Yeah, I guess as a team, there's just so much that was going on in the background. Were there, and maybe I missed this, but when you think about the other people that you could have tapped, were there other people on that you would have liked on your team from different professions? Or did you feel like, let's say you had who you had, how did you feel about the synergy of the types of roles that you all have and how they overlapped? Was there any observations that you took away from that in terms of things you were surprised by or, not surprised by?
I think that one thing that would have been really helpful would be to have also a social worker. I think that would have been another just great person to have on the team. But overall, I thought we managed very well with our fictional patient. And I think we came up with some really good ideas, but, definitely the more help, the better.
Mhm. And what about your roles? Did you feel like, were you surprised by anybody's roles or the areas in which you might have overlapped?
I think that we all sort of put our brains together. And like for me as a dental student, we didn't really address any dental focus needs, but we are all healthcare providers and have certain experiences with certain patients. So I think this patient in particular didn't necessarily wasn't totally directed at being more focused towards one health profession or another. We just all shared our experiences and chimed in where we could to help find potential interventions to help them in the future.
That's great. I can say one of my experiences facilitating a team that had a dental student, you all possess an amazing skill to calm down anxious people who might be afraid of sitting in that dental chair. And just that demeanor as a whole, it transfers to anything that you do. And so you might not think of it as a skill that you're trained in per se, but that aspect of your profession, I always think I've always just respected. So I think, sometimes when you show up and you feel like there's nothing you can do because it's not a problem related to your field, I think that these are the types of experiences where you realize like, oh, wow, like brush my shoulder off. I got this. So nicely done.
That's great. Thank you
Thank
so
you.
much, Tessa and Drew, for sharing your insights with us.
Hello, everyone. Thank you for listening to our interprofessional collaboration exercise here, where we will be analyzing and addressing some of the health disparities in rural Maine, specifically surrounding a case study that was created for a hypothetical one for patient Naomi Alice. So Naomi is a 32-year-old Black Somali female with a history of chronic migraines, rheumatoid arthritis, hypertension, and generalized anxiety disorder, who presents to the emergency department with an acute headache for 2 days. The patient has been experiencing some elevated levels of stress and exhaustion, as well as some malnourishment and some potentially hypovolemia and dehydration that was identified in the ED as some potential exacerbating factors. It was also noted in the ED that she poorly manages some of these chronic medical disorders with medication due to some limiting factors, and she has a intermittent relationship with her PCP.
So I'm actually going to skip over this slide because a lot of it is covered in our framework, which is the slide after this one. So we wanted to make sure that we were looking at all of the factors that can be affecting her health, which would include the built-in environment. She lives in a rather rural location. Her personal self-influencing behaviors, such as smoking daily and having a low level of exercise and not having the best nutrition. We also looked at healthcare status affiliated factors like having poor access to a PCP, as well as social, cultural, and economic factors. On the side, we also looked at some modifiable and manageable risk factors, some that were already covered, like hypertension and generalized anxiety disorder, and some that are non-modifiable, like her family history of hypertension, RA and GAD, and some other protective factors as well.
So in terms of applying interventions to this patient, we did have some acute interventions that we identified that we could initiate in the ED. The first and foremost would be medical management of her acute migraines. So we had a number of medications and some IV hydration and some electrolyte corrections that we could do to help her with her acute presenting symptoms. We also wanted to make sure that we provided her with a note work to mitigate any challenges surrounding her, any work that she missed or would miss over the next couple of days that she may have to recover. And then also, given her malnourishment, even though that was largely influenced by her busy schedule and her job, we did want to make sure that once her nausea and her migraine improved, that we gave her some nutrition there in the ED, and then also offered discussion with a social worker about some maybe acute diet modifications that she could consider to prevent this from occurring in the short term.
In the long-term interventions, we are interested in having the patient consider enrolling in Maine Healthcare. It has a more socially supportive package. It has less co-pays, and would offer some more social services for the patient in delivering care at home. One of these services would be exploring telehealth providers for a primary care provider or a therapist to help manage the patient's generalized anxiety disorder. We would also be interested in conducting patient education with a nutritional specialist, as would be recommended and referred to by an ED physician. We are really focused on informing the patient on factors that could be exacerbating their migraines and how this could be prevented and improved by managing nutritionally, hydrating, and addressing those well-rounded factors. Lastly, we would be interested in conducting and exploring the opportunity of doing osteopathic manipulative medicine treatments. Some research has demonstrated that treating OMT migraines has been effective in the acute presence and also long-term prevention. So this would be something we would explore. There is a free clinic here at University of New England College of Osteopathic Medicine that a patient could come and have monthly or bi-monthly treatments.
Some other considerations that we were looking at were prescription deliveries. Since our client lives in a relatively rural area and has poor access to reliable transportation and to her PCP, deliveries can be made through Maine Health with any prescriptions prescribed by her PCP or therapist for free. We were also interested in looking at cultural community engagement. There is a group in the greater Portland area called the Somali Community Center of Maine, and they offer a lot of different resources for immigrants, such as financial health, health literacy, and assistance with housing.
Lastly, our key takeaways as a group is that the most important thing to do is have a patient-centered approach. We want to tailor a personalized care plan with a multidisciplinary care team to take care of all the patient's needs and do an in-depth review of the patient's social determinants of health. There are so many factors that make up and contribute to a patient's health and well-being, and to do that as an integrated multidisciplinary healthcare team, we have to consider all of them. Lastly, we really want to emphasize the importance of establishing rapport and trust with populations, especially immigrant populations. We want to continue relationships with them and create an open line of communication for long-term success and care. Most importantly, we want to approach each encounter with cultural and social humility. Thank you so much for your time.
Thank you. So I believe that we have all three of the presenters here in the room. So just give a little wave so people know who to look at. We just have a couple of quick minutes left before we wrap things up. I'm curious if any of you feel like you could share what you're going to carry through to your career most from this interprofessional opportunity with FIT. What are you taking with you in your backpack as you leave UNE?
Well, definitely the fact that it takes an entire team to care for a patient, and we would have valued even more specialties within this, hypothetical case. Typically it's nursing, it's PT, it's physicians, it's social work. There's so many factors contributing to it, and then social community support. So I think the big picture is that whole person health takes a whole team with multiple specialties to approach and improve well-being.
That's great. And the last question I'll ask is, were there any surprises in the resources for our community that you find? I know sometimes when you peel back the layers and realize what a complex individual like this situation needs, that sometimes we have a lot more or a lot less resources in our community. And I'm just curious if your team found anything notable in your trying to support this client.
What I found the most surprising was the resources for specifically Somali immigrants in the greater Portland area. I know that Maine houses a lot of different immigrants from Africa, and I was really surprised that they had the in-depth resources that they had. Like, it wasn't just like housing and finances, it was also like health literacy, learning English, and just, I thought it was a really great resource, and I was really surprised to see it.
Well, great. Thank you all for being here today and attending and hearing all the amazing work that's done. Thank you for those of you who hung out in track 1 today, whether part of the time or all of the time. I hope that you learned a lot from all the individuals and facilitators and all the amazing IPE work that's impacting our direct UNE community, but our community at large.